Welcome, everyone, today to the Marrow Center program, MS, its symptoms, current treatments, and advances with Dr. Salim Chahin. He completed his medical school at University of Damascus and did the neurology residency at the University of Iowa, where he was chief resident in 2010 and 2011. He trained in MS care and research at the University of Pennsylvania, where he also received the Master's of Science in Clinical Epidemiology. Dr. Chahin moved to Washington University in St. Louis in early 2017 and joined the John L. Trotter MS Center. Dr. Chahin is the MS Fellowship Director at Washington University, and his practice is dedicated to the care of people with MS and related conditions. He is active in clinical research, exploring biomarkers and outcome measures that enhance knowledge on MS disease, on the MS disease course and disability prediction. So please welcome Dr. Chahin.
Thank you very much, Judy, for a nice introduction.
You're welcome.
Should we go ahead and get started or give people a few more minutes?
Let's go ahead and get started. And then
Okay.
anyone comes in, I will let them join us.
All right, everyone, I'm going to go ahead and share my screen. I just want a nod or a confirmation that you can all see my screen.
Yes.
Okay, thank you. Okay, now let me try and hide this, minimize the Zoom window as much as possible. Okay, so thanks again for joining today. We are going to cover a lot of topics in a relatively short amount of time. I realized after we decided to do this talk that we didn't kind of talk specifically about what the title is going to be, what the content is going to be. And then when I got the title from Judy, I realized, boy, that's a lot. I could have probably a few lectures each on what is MS, what are MS's symptoms, how is MS treated, and then what are some of the exciting advances. But we're going to try and shrink all of that and fit it into this 1 hour. So again, we're going to start by reviewing what MS is. We're going to talk about common symptoms that people with MS experience. We're going to talk about how do we currently treat MS and what is coming in the pipeline, both clinically as well as perhaps still in the lab phase that is exciting in the treatment and improving the lives of people who have MS. So what is MS? MS is a chronic, lifelong, autoimmune, inflammatory, degenerative disease of the central nervous system. That's a lot to kind of take in, right? So autoimmune means that the immune system mistakes a part of the body for something foreign and goes on the attack. Inflammation, it's pretty, we all are familiar with what inflammation means. So the result of this immune attack is focal inflammation in the brain and the spinal cord. That's what the central nervous system is. And then degenerative, these focal areas of inflammation will cause focal damage, but then there's also over time more widespread damage in the brain and the spinal cord. So people will have a variety of symptoms depending on where those lesions tend to occur. And we're going to cover some of that later. What happens in MS? Again, we could probably spend a few hours just going over the immunology. This is it's a simplified figure, but it still has a lot. So we are not, don't worry, you do not need to be familiar with a lot of what's going on here. Only just to note that there's activation, something, we don't know what that thing exactly is, activates the immune system in the blood. That's the periphery. It could be some virus. So we're going to talk about the virus theory in MS in a little bit, but it's probably a combination of things that activate the immune system. Then these immune cells are able to cross from the blood into the brain and the spinal cord, and they cause inflammation. They go on the attack. They specifically attack two things: myelin, which is the protection around the nerve fibers, just like any electrical cord. You always have kind of insulation around it. That's what myelin is. It's insulation around the fiber, as well as the cells that produce the myelin. They're called these oligodendrocytes. They're these cells that they've got kind of, they reach out all over the place and they produce this myelin. So again, this is a schematic of what myelin is. This is a big nerve cell body. This is the fiber, the axon that goes on to connect with other nerve cells or with other parts of the body. And within the central nervous system, myelin is these kind of like segments that protect the nerve fiber. What it does is it speeds up the nerve signal and protects the fiber. So when there's inflammation that causes damage to the myelin, this will result in symptoms because either the conduction is slower, just think about your internet connection if it becomes slower, or because there's been damage. There's been permanent damage to the nerve fiber and sometimes to the cell itself. We think of this damage happening in lesions in the white matter of the brain. On this scan, it's actually the darker part. So these are kind of typical MS lesions. We're going to cover more MRI pictures in a bit. But we now also recognize that MS does not spare any part of the brain or the spine. This is a brain autopsy of a person who died with MS, and you can kind of see this is the normal white matter right here. This is the normal cortex, the gray matter, and you can kind of see these dark spots. These are all the MS lesions that have accumulated over the years. Some of them are smaller, some of them are bigger. So we talked about this concept of degeneration or damage. When does that happen? It probably starts from the beginning, but earlier on, especially in people who present with relapsing MS, they've got a lot more inflammation going on in these focal lesions than there is damage. But as time goes on, you see, as the patient gets older, as the MS gets older, you see less of the inflammation and more of the damage. When I'm talking about this to my patients, I say, think of the immune system here as a bad guy with a sledgehammer causing potholes in your street or your driveway. Those are the lesions. That's the inflammation. Over time, there'll be less of that bad guy causing these potholes and more of the cracks in the street or the driveway because of just disuse, right? Years of having these potholes that are not well fixed. Okay, so who gets MS? Almost any MS talk that you attend will mention that the onset age is anywhere between 15 and 45. It's very typical for us to see it in people in their 20s and 30s, maybe early 40s, but we have diagnosed patients in their 50s all the way up to their 70s and 80s. Oftentimes when it's that late, they've probably had it for a while, but either it was mild or they didn't recognize it, misdiagnosed. There's a lot of reasons why there may be a delay in diagnosis. And there are also children younger than 15 that can get MS. Fortunately, it's still rare in children. The majority of people who get MS are women. There is an MS geography where there are more cases the further you move from the equator. And this has over the years given us a hint as to what causes MS. Some newer studies suggest that this geography thing may be disappearing. It may be looking more and more equal throughout the world. How many people have MS? There was a study sponsored by the MS Society a few years ago now that estimated that at least 900,000 people in the US alone have MS. So the number is in the millions worldwide. The number one question that I get from my patients is, will my children get this if I have it? And the answer is most probably not. And we get this from facts like knowing that up to 90% of people who have MS do not have a family member with the same diagnosis. So most people will not know anyone in their family who has had MS. But if you also look at the risk, so again, this 900,000 number translates to about a risk of 0.1% in the general population. If you have a first degree relative, so a parent, a sibling, a child with MS, the risk goes up to 4%. So it is higher than the general population, but it's still very low. In fact, if you take two identical twins that share all the same genes, the risk if one twin gets it, the risk in the other twin is only 30%. So it's not just genetics. And that's why I tell parents usually, don't worry about your kids. The risk is still very low of them getting it, even if you have the diagnosis. So the last few slides kind of gave us some hints as to why MS happens. The short answer is, again, we could take hours to talk about it, but the short answer is we don't know. There is definitely a genetic predisposition. You need to have the right genes to get this or other autoimmune diseases sometimes. But there's also an interaction between the genes. You have to be exposed to something in the environment that triggers this immune response. So that's kind of the simplest way to look at it is, and that's why even in twins, not both of them get it, is it's a complex interaction and likely between more than 2 or 3 or even 4 things. Over the years, we've been able to identify some risk factors. One of them includes low vitamin D, definitely low exposure to the sun. And this goes back to the equator theory. So the further you move away from the equator in both directions, you're getting less time during the year with enough sun exposure and even less time during the day. And there have been studies linking low vitamin D in the blood of people who eventually develop MS years before they have the diagnosis. Smoking and tobacco use in general has been now repeatedly shown to be a risk factor for developing MS. The exact mechanism of why is still not clear. People with a high BMI are also at a higher risk for developing MS. And then we come back to the virus theory. That has always been the most attractive, is that we are exposed to some kind of virus. This virus triggers the immune system to act. And then the immune system mistakes the myelin for the virus because there's some resemblance of the surface of the receptors, what's going on the surface of the virus and the surface of the myelin. Epstein-Barr virus, the one that causes mono, is the one that's been most studied. And for years, whenever we give an MS study, we've always mentioned this. We talk a little bit more about the Epstein-Barr theory. I'm going to come back to that in a minute. But again, just a little bit more about low vitamin D. The first bullet point is what I just mentioned, is that MS is higher in areas where people have less sun exposure. There's been several studies showing that the risk of developing MS is higher in people with low vitamin D levels. And then there's some genetic factors that predispose some of us to have a low vitamin D are also linked to an MS risk as well. Smoking has been associated with an increased risk of MS. People who smoke tend to have worse MS outcomes. And stopping smoking is associated with better outcomes in people with MS. So here's the Epstein-Barr virus theory. It may have to do with when you get infected. 95% of us have been exposed to this virus at some point in our lives. If you are exposed to it at a younger age, your risk of MS is not as high as later. So, and this used to be true again in poorer countries, which tend to be located close to the equator. Children at a much younger age get exposed to the virus, and they often don't have any symptoms from it, so they will not get mono. Whereas we're more familiar with people who are exposed to this virus either as teenagers or in their 20s or even 30s, and they get infectious mononucleosis, mono, and usually they're bed bound for at least a few days. And their studies have shown a link between mono and MS. So there may be something about how the immune system responds to the infection that predisposes people to MS, meaning a later response may be different than an earlier response in life. EBV has just recently, in the last few weeks, kind of come back into the limelight in a big way, because there was this study, and I shared figures from it here, similar to the vitamin D studies. The authors were able to look at blood donated by people. This is from the military, so I don't know if donated is the right word, but blood obtained from people who enrolled in the military over many, many, many years. These people were followed for many years. And then they were able to identify about 900 people who developed MS. And they went back and looked at their blood before they were diagnosed with MS. And almost all of them were positive to this virus. And interestingly, those who were not positive turned positive. So they had mono up to 5 years before they had MS. Only one person out of 800 plus in that big sample did not get EBV, was not positive to EBV before getting MS. Now, again, keep in mind, even in people who never develop MS, 95% of them will have been exposed to EBV. So it is not the fix all, like treating this or addressing this is not going to fix everything. It's more than just one virus. And then within the last few days, there was another study that showed how the link between, that expanded on our knowledge of how the link between this virus and MS works. So again, a lot to digest here, and I'm sure some of you may ask me more questions about it later. I'm happy to tackle those. What does MS look like? For most people, about 85% of people, it will start with an attack. And often the first attack, this is someone at baseline, they get an attack and then they go back to baseline or near baseline. The first attack, we call it clinically isolated syndrome. Again, most people will have this pattern if they will get an attack and then they'll go into remission and have another attack, hence the name relapsing remitting. After about an average of 15 years of living with relapsing remitting MS in people who are not treated, these are studies from the 80s and 90s before we had medications, they will start to show more of a slow, gradual decline. Their walking will become slower, their weakness will be slightly worse every year. That's called secondary progressive MS. So you no longer see the relapses here. It's more of every year is a bit worse than the year before. And about 15% of people, they never have relapses. They just go from the beginning, they have a slow gradual decline. And this is called primary progressive MS. Inflammation is what drives these relapses or these bumps. Inflammation probably drives this as well, but to a lesser extent. This mirrors that degeneration or that damage that we talked about. How do we diagnose MS? First and foremost, we diagnose the patient and not the MRI. The number one consult we get at our center is someone who had an MRI for, there's many reasons to get a brain MRI. Headaches, someone was in a car accident, they needed head imaging, and someone sees some white spot. We don't diagnose MS based on an MRI. We need to hear from the patient, and the patient has to have typical symptoms. We're going to talk about them in a little bit. Next, we want to make sure that there's no better explanation for what this person is complaining of. We do use additional studies. Definitely, we use MRIs, we use blood work, we do a lumbar puncture known as a spinal tap or spinal fluid analysis to look for inflammation. So we do use other studies to help us confirm the diagnosis, but it all starts with what the patient complains of. And again, this is an MRI with typical brain lesions. I usually go over examples of MS lesions with my patients just so they kind of know, because again, not every white spot on the brain is an MS lesion. It has to be in some typical location. It has to have an orientation and a size. This is another example of MS lesions when we're doing an MRI, looking at someone from the side, back part of the brain, responsible for balance. Sometimes you can also see some lesions. And I'm sorry, I did not point out here. Let me see if I can go back. So I'll point out where the lesions are. So again, these are cuts through the brain. Here's a few of the white matter spots. Some here, here's another one. These are called periventricular lesions because they're around the ventricles. Same lesions seen from a different view. Kind of see how they're peripendicular to this dark area. That's the ventricle. So that's a very, very typical MS lesion. Back part of the brain. Lesions here can cause balance problems or double vision or other issues. Spinal cord, so MS, we frequently think of the brain, but MS can also affect the spinal cord. There's a very small lesion in the upper. This is, to orient you, this is someone's neck. Here's their nose, so this is the back of their neck. Here's a lesion in the spinal cord right here. It's small and faint. This is in someone's mid back, and here's a small lesion here. If we do a cut like so with the MRI, we see it. This is the spine, and the lesion is the white thing inside the spine. Lesions in the spine tend to mostly cause symptoms in the legs, as well as possibly bladder symptoms. Speaking of which, we'll transition to talk about symptoms of MS. So there's typical symptoms, right? Those we're going to cover things as they typically present. Obviously, weakness because of spinal cord lesions affecting motor pathways, stiffness. Optic neuritis is perhaps the most common manifestation of MS. We're going to talk about it in more detail in the next slide. People can have balance issues and coordination, tremors, a lot of sensory symptoms, tingling, burning, numbness. People can have double vision, vertigo, room spinning sensation. I mentioned bladder symptoms. We're going to expand on those. And fatigue is another big symptom that is often under-recognized in people with MS. So what is optic neuritis? Optic neuritis is inflammation in the optic nerve. That's the nerve that connects from the back part of the eye, goes into the brain. People often complain of blurred vision. It's usually central. So if they're looking ahead, and it's usually only out of one eye, they will kind of see a dark spot. So it's not necessarily complete blindness. It's more like blurred vision. And this is just an example. Obviously, people can have the dark spot in any parts of the vision, but it's more common to be in the center of their vision. And they will sometimes complain of pain with eye movement. When the inflammation happens in the spinal cord, we call it transverse myelitis. The word partial is because it does not affect the entire spine. So people will have a combination of weakness and numbness in the legs, some trouble walking. And again, this is an example of a lesion in the spine right here. We're looking at someone from the side on this MRI. Here's the MS lesion relative to the rest of the spinal cord. And this is just a figure to illustrate that in MS, both legs are usually not affected equally. The symptoms are usually worse on one side more than the other. Let's go over some of the other symptoms. So I mentioned fatigue. Fatigue is actually probably the most common symptom. It is a leading cause for departure from the workforce for a lot of patients. It's important to keep in mind that fatigue could be due to MS, but a lot of things can cause us to be tired. So sleep problems, thyroid problems, having anemia, all those things can also lead to fatigue. Low mood. If we have depression, it can cause fatigue. And if we have fatigue, it can make us feel depressed. So there's a lot of interaction between mood and fatigue as well. So this is why it's important to make sure we rule out other causes of fatigue before we blame it on MS. Although again, as I said, it's very common in MS. We often divide it into physical fatigue, which means your legs just can't take you as far as they should. Cognitive fatigue, which means that you're less able to focus or multitask at work. And then sometimes it's more subjective, where someone just says, I wake up feeling tired. And there's objective fatigability, meaning if I'm measuring someone's distance, I will notice that the more they go, the more tired their legs appear. How do we treat it? Energy conservation. We work on improving sleep, exercise, and then there are some medications like stimulants that may help with certain types of fatigue. Bladder problems are common in MS as well, and they are often due to lesions in the spine. There's a few types. I'm not going to go into them in detail, but there's where the bladder tends to be overactive and always wants to empty. And so people feel like they constantly need to go to the bathroom. Though this type of bladder problem has a lot of medications that we can use to treat it with that can relax the bladder. We can even inject, well, not we, a urologist can inject Botox into the bladder to relax it. There's the type where the opening of the bladder doesn't work as well. It doesn't coordinate with the bladder. So when someone wants to go, they just can't because the opening isn't working. And there's one where the bladder doesn't feel when it's full. So people don't feel like they need to go until their bladder overflows. And oftentimes the first one I mentioned is the most common one that we hear from our patients. But sometimes we hear a combination of all two or all three. Cognitive dysfunction. So for the longest time, whenever I would ask students, I would say, you know, if I asked you to Google a picture and bring it over because we're going to give a talk about someone who has MS, they will come back with a picture of someone in a wheelchair or someone using a cane, right? Because we think of MS as causing physical disability, but actually cognitive problems are very common and they can happen early. They can be subtle. People can blame them on other things, but if you ask about them, people will tell you that they're experiencing them. And obviously, as more and more of us do more cognitive type work, this is now another leading cause of people not being able to work. And then I apologize here. I just realized that we don't have the manifestation. So common ways cognitive dysfunction can affect MS is what we call executive functioning and working memory. So again, it's like if you're having a busy day, trying to multitask, do several things at the same time, having those MS lesions in the brain will cause more trouble. You will be less able to do that. There are no medications to treat this. You can kind of give someone stimulants, but most often we do speech therapy, occupational therapy. They can help people cope with these symptoms. Sticky notes is an example of ways to cope with some of the cognitive dysfunction that happens in MS. This is not dementia. In most people with MS, their cognitive problems do not look like Alzheimer's dementia, for example. It is usually milder. As they get older, it may become more obvious. Just recently saw a patient that her MS has caused her enough memory problems where she couldn't remember the last time she saw me or the last time she called for a refill, but that's about it. It was not affecting her daily life in any other way, like you think of Alzheimer's disease, for example. Spasticity, cramps, spasms, common lower extremities, legs more than arms. It can happen anywhere in the body. It is very common as well. Spasticity is our body's response to weakness. So a balance between some weakness and some spasticity is helpful. You don't want to overdo treating spasticity. But how do we treat it? Rehab, stretching. I tell people stretch, stretch, stretch. And then we can use muscle relaxants and we can use Botox as well. So we talked about the disease itself. We talked about how it presents, how we diagnose it. Let's talk about how we treat it and what exciting things may be coming down the pipeline as well. This is a figure that shows the dates of, or mainly the years of the FDA approval of all the currently available MS treatments. And you can see that for the longest time, between the 90s and all the way through the late 2000s, we had very few options. Anything that has interferon in the name, they kind of work similarly, but we had very few options up until about late 2000s when we started seeing a lot more. So if you look at just the last 10 years, there's been double or almost triple the number of approved drugs compared to this decade. So it's been really exciting. I finished training right around, I went into residency right around here where I knew that a lot of these things were in trials. And then I finished and went into fellowship where a lot of these were coming on the market. And again, since moving to St. Louis, which is kind of right about here, so many other things have happened. I mean, our way of practicing has changed significantly because of availability of options. So currently, as it stands, if you check the MS Society website, you will see that we have 10 approved pills. Some are generic, but the total is 10, 9 approved injections that people will do at home, and 4 infusions. We do not need to go through the names of the different drugs or how they work. That again, that requires us to add on a couple of extra hours to this talk, but I wanted to list them on these slides. So we've got mainly the interferons, and then glatiramer acetate, which is called Copaxone, that's the brand name. One of the newer injections kind of belongs here because it's an injection, but it's actually one of the much newer and stronger drugs that we have. You have 10 pills. Some are generics, but most are not. And the list is growing. More and more pills are expected to be approved in the next few years, as we'll see later. They work in very different ways. They range from mild to strong. So again, it's good to have options. And the blockbusters have become infusions. So for the longest time, we only had natalizumab or Tysabri as our only infusion. Lemtrada was approved about, I think, maybe 10 years ago now, maybe a little bit less. Ocrevus was approved in 2017, and it has proven a blockbuster for us because it works so well. It's an infusion every 6 months. And I think Now that we have options, usually infusions tend to be the stronger treatment options. Now that we have the stronger treatment options, we have been able to treat MS better. We are not afraid to start someone on a strong medicine from the get-go. We know we have options to go to if they fail one drug or they don't tolerate one drug. So again, having all these available options has really transformed how we treat our patients. When we sit down with a patient, let's say someone who's new to, you have new diagnosis, we're sitting down to talk about what medicines they should consider. The list has become overwhelming. You can't tell them here, there's 20, almost 20 options or 20 plus options. Go ahead, read about all of them and let's decide. This is not as easy as treating blood pressure. There are some guidelines as to like first line treatments for blood pressure. There are some guidelines, but they're not perfect. There's still research is still ongoing to understand how to best approach treatment. What I can leave you with, again, with the time allotted, is we have mild options and we have highly effective or highly efficacious options. Keep in mind that the stronger the medicine, the more risks are associated with it. And this comes mainly from the drug being immunosuppressive. All of the drugs that I showed you work through affecting the immune system one way or the other. Some are milder and technically do not cause immunosuppression. Some are stronger and cause significant immunosuppression, something that we have had to contend with during these last couple of years of the pandemic that we've lived through, and we continue to do so. So again, you have to balance how strong do you want the medicine to be with the risks of that medicine. There's two ways to approach this. You could either escalate, meaning start with the weakest drug and then see how the patient responds and keep making changes until you get to the right option. There's the high efficacy approach, kind of the opposite point of view, which says it's probably better, because remember how I said inflammation tends to predominate early? If you're meeting someone with early MS, it's probably better to hit it with the hardest, strongest medicine you have for maybe a few years. I don't know how many years yet. Again, the jury's still out on that. And then reevaluate. Make sure you control things really well from the beginning. And then if someone's doing fine 5+ years later, maybe you could go down on the medicine. And those are the two approaches. I can tell you that, again, with the availability of the stronger drugs, more and more of us are using this high efficacy, early high efficacy treatment. We look and see how severe someone's MS is. There's a lot of factors that we take into account. How many relapses have they had? How old are they? Men tend to have it worse than women. How many lesions are there on the brain? Do they have lesions in the spine? What did their spinal fluid look like? So there's a lot of things that I take into account as I'm having this conversation with the patient. And it's still hard to convince me to give a very strong medicine to someone with very mild MS. But anything that's not very mild MS, I think all medications are fair game. We sit down, this is usually more than a one-time conversation. We narrow the choices down. We give the patient reading material. They read some more about the options. We come back, have another conversation, narrow things down more. Then we start looking at insurance and approval and things like that. What I wanted to share with you is there is research to suggest that it's important to start medicine early. It makes a difference. And it's important, and it may be important to start strong treatment and high efficacy treatment early. Think of the guy with the sledgehammer. If you looked out your window and you saw someone causing damage to your property, you want to make sure you choose whatever protection option you have to keep that guy away and for the guy not to come back again. Hopefully I'm not being sexist by using a guy. You can choose the gender of your choice for the person destroying your driveway. That's the idea, is that you want to do it early, and you want to do it with the option that you think will definitely keep the bad person away. So I'm going to share just a couple of figures. Pictures speak louder than words. This is a figure showing that this is the risk of long-term disability in people who have MS, and we're talking about years, up to 17 years. People that start treatment within 5 years of MS onset do better In fact, the lines separate compared to people that start medicine after 5 years. The lines separate and they never meet again. So over time, they will continue to do better. People who start even some of our weakest medicines do a lot better than people who are not treated. If this is started within 5 years, it matters less if we wait after 5 years. A figure comparing stronger options versus less strong options shows that, again, there is some separation where people started on stronger medicines tend to do better over the long term. This is up to 9 years. Although, if you find that someone is not responding to a medicine, even if it is one of the less strong options, and you make a switch before 5 years, you still make a difference. One more figure. This is supporting the idea of going strong from the get-go. People who within 2 years started with a high efficacy, a strong option, had better disability scores 6 to 10 years later compared to people who didn't start high efficacy until after 4 years. And again, you see it from the figures, that the line separating between early, blue, which is early, and red, which is late treatment. So the gist here is, we want our patients to start medicines early. We want to make sure we follow them closely, no matter what option we choose. It's important to follow people closely and make sure that they're not having relapses or their MRI is not changing. This is why my patients complain and say, why do I have to see you every 6 months like clockwork? Why do I have to do a yearly MRI? That's why. It's because I'm looking out to the future. Because people say, I feel fine today. Why do I need to worry? And I say, I'm worried about, I'm keeping an eye out on you today because I will guarantee a better future. And then more and more MS doctors are using the strong options from the get-go. If we have time during questions and people want to ask me how has COVID affected these decisions, I'm happy to answer that. But for the sake of time, and I want to leave at least about 10 minutes for questions, I'm going to move on to the other exciting part of this topic, which is what advances are there out there in MS treatment. First, let's talk about biomarkers. So listening to my talk, you would say, all right, it sounds like they've got things under control. They see the patient, examine the patient, make sure the patient is not having an attack or a relapse. Great. We do yearly MRIs on most of our patients, make sure the MRI is not changing. We've got things under control. We may, however, be missing things. Sometimes there's a delay in when things change on MRI. So we've always looked for some type of blood biomarker, something that I can draw in clinic, that I can get a result, and that can help me with potentially diagnosis, but also prognosis, telling someone where their MS is going to be. And lastly, with treatment response. And in recent years, we have a very promising biomarker. It's called neurofilament light chain. So neurofilaments form the backbone of nerve fibers. Anything that destroys the nerve fiber, it does not have to be MS. It could be head trauma. It could be stroke. It could be a number of things. Anything that damages the nerves will release these neurofilaments. They will first go into the spinal fluid, and then a much smaller concentration will make it into the blood. For the longest time, we could only measure these in the spinal fluid. And you can imagine asking someone to do more than one spinal tap is not going to go well. Sometimes people do it for research. Sometimes people have to do it, but monitoring the disease through repeated spinal taps. And I see that question. I promise I will address it later, but that's a great question. So we needed a better way to measure these. And finally, we have more sensitive technologies that allow us to measure the minuscule concentration of these neurofilaments in the blood. This has been out now for a few years. It has revolutionized how we think about MS to a certain degree. Some centers now use this, even though it's not yet an FDA approved lab, but some centers are using this to track patients. I think there's still a few kinks to work out, but it's promising. So we know that if someone has a relapse or someone has an MRI change, their NFL level will go up. the analogy that I give is if you're standing at the end of a street and you know that there's a house being demolished, the MRI is technically, if you think about it, the MRI is the picture you get of the satellite picture you get of that house being demolished. The NFL level is you seeing the trucks leaving with the debris. That's why they're going to correlate. Yes, whenever I see damage on a picture, I'm going to expect the level of the marker of damage to go up in the blood. It seems that people, when they're first being diagnosed, if they have high levels of NFLs, of serum NFL in the blood, their MS is going to look worse later. Still needs to be worked out. There's a lot of things to work out here. We don't really know what's a normal level for a healthy person. The levels go up in all of us as we age. So this is promising, but it's not fully some of my research is looking into this, trying to see if I can come up with a blood level where I can tell someone, listen, all else being equal, I think you're going to do worse. Let's choose a stronger option from the get-go because we've got things we need to treat. Most importantly, and for the purpose of this talk, NFL levels go down after treatment. So it is another way where we can potentially give someone a medicine and then we recheck their NFL level. And if it's not going down, maybe the medicine isn't working as well. And then that could allow, even before the MRI changes, even before the patient has symptoms, maybe we can tell them, listen, we think you're not responding well. So this is where I think these biomarkers hold a lot of promise. And I want to show you, this is a figure from the Kesimpta or the ofatumumab trial, I'm sorry, where they checked these NFL levels in both the Kesimpta arm as well as the comparator arm. And you can see that early on, after people started treatment, levels on the stronger drug went down a lot more than levels on the less strong drug. So there's promise here that we'll be able to use these markers in the future. Another thing that makes me optimistic is a few studies looked at people with progressive MS. This is kind of later on in the course when someone's no longer having MRI changes or relapses, but as I mentioned, their MS may still look like it's getting worse year after year. They showed that treating, and this was only one drug, but treatment compared to no treatment resulted in reduced NFL levels even in those people. So as you kind of, again, standing at the end of the street, seeing those, it's not trucks anymore. It may be more like carts because it's more slow brewing damage that's happening over time. Even if we don't see any active inflammation with our eyes, treating with medicines that target inflammation seems to cause less damage. Again, encouraging, promising, not the foolproof thing that we want to say we should continue treating people way into their 60s and 70s, for example. There's still a lot of unknowns here, but I think it's promising. And another promising way this biomarker is changing how we think about MS treatment. Other things that I wanted to mention is the new treatment options that we have. So there's people ask me, what are you excited about currently for MS? And I say, well, I think we've reached a period where there's enough medicines, enough treatment options that it's hard. I don't feel like I'm going to run out of options. And it's hard to imagine another exciting option that's going to come out that's going to change how I think about treating MS. I think the option would be something that's very strong but very safe. But being a realistic scientist, I don't think that thing exists. Having said that, there's a couple of things that are worth mentioning. There's these drugs called BTK inhibitors. They affect B lymphocytes. And our experience with the drug Ocrevus or ocrelizumab has been that, which is an anti-B lymphocyte drug, is that targeting B lymphocytes really works in MS. For the longest time, we did not know that, but now we know, and we know that it works well. So this is a class of drugs that affects the B lymphocytes in a very different way than Ocrevus. These are pills. So technically, some people may prefer them over, say, an infusion or an injection. The exciting thing about them is that there's at least 3 of them in trials. Most are phase 3, so they're reaching the end of the last big trial right before FDA approval, and they have the largest number of progressive MS trial, which is, I think, what's most exciting. Are they going to show that they work? The jury's still out, obviously. That's why they're doing the trial. But I think there's promise that we're going to have more options to treat people and more options to treat people with progressive MS. I want to mention this compound. It's an investigational drug also currently in trials that targets B lymphocytes that have been infected with EBV. Remember this whole EBV thing that we talked about? So this is one way to address it. And there are ongoing trials in progressive MS for this compound. Again, a very promising way to think about treating MS by specifically targeting the cells that may be causing the damage. There is also an EBV vaccine that may be coming, although this may be, perhaps, I don't know if an EBV vaccine, if a patient with MS takes an EBV vaccine, if that's going to make a difference, or if it's going to be something future generations will see, meaning if, say, all children receive the vaccine, will we see much less MS in the future? Hopefully the answer is yes. We have to talk about stem cells because a lot is going on in stem cells. For the sake of time, I'm not going to go through every single type of stem cells, but when people talk about stem cells, I want you to differentiate between two things. There's bone marrow transplant, which affects the hematopoietic stem cells. These cells are found mostly in the bone marrow. And these are the cells that we target when we talk about someone undergoing a bone marrow transplant. The other type of stem cells, when you hear someone went to and got a stem cell infusion, are these, the mesenchymal stem cells. These are found in several parts of the body, and they can help other cells function properly. A subset of them is known as neural stem cells, and sometimes you can induce them, and it's called an induced pluripotent stem cell. So briefly, let's talk about bone marrow transplant. Traditionally, you think about bone marrow transplant in people who have certain types of cancer, specifically blood cancers. Autologous hematopoietic stem cell transplant, HSCT, has been now shown in several studies to be effective in treating relapsing MS, especially in people in whom other treatment options do not work as well. Why don't we just adopt it as a treatment? Because it has a lot of risks associated with it. People have to undergo chemotherapy and then undergo the bone marrow transplant. They have to reside in a bone marrow transplant unit for days to weeks. So it's not a trivial thing. But there is now a large multi-center trial called Beat MS. WashU is one of the centers where we're going to be recruiting people who have failed other treatment options to see if they would respond to this bone marrow transplant. The other, when you read news or Facebook shares about stem cells, they're often talking about these mesenchymal stem cells. And again, the idea is you give someone stem cells, they help repair the damage. I think that's very promising. There's now a few studies showing that if you inject these into the spinal fluid, into the central nervous system directly, some patients are showing mild clinical improvement. So again, I think we're in that promising phase, but it's not there yet. Stem cells just randomly infused at one of those health centers. You can get it in the US, you can get it outside the US, it's not FDA approved. They don't work. We don't have proof that they work. And studies also showed that these cells do not reduce inflammation. Last slide is on repair. We talked a lot about stopping the person causing the damage. But the next thing you do once you stop the damage should be that you should help the body repair. And the best way to do it, because it's much easier to repair myelin than to regenerate nerve fibers, is to do it this way, to tell the cell, this oligodendrocyte, that's the cell that produces myelin, to tell it to recruit more of them, make sure they survive, and make sure they grow, they differentiate, they split into more and more cells to produce myelin. This is a figure from a paper, and I'm sorry, I realized I did not copy the reference down here, showing all the different drugs that are at several stages of research. Some have undergone clinical trials. Some are drugs that are already approved for other indications that work either on the surface of the oligodendrocyte or within the DNA of the site to make it produce more myelin. It is my vision that in the future, and I'm sorry, before I say that, I think people need to take this drugs that help repair early. Again, you do not want to wait 20 years to repair your driveway if you can. You want to try and patch up those potholes as soon as you can. So it is my vision that in the next 5 to 10 years, people will be taking a drug to stop inflammation plus a drug to promote repair. And with that, I will stop and take questions. We have 10 minutes. All right. So first, I'm going to take a sip of water if everyone's okay with it. Okay. First question is, what do you do when the MRIs are stable, but disability continues to increase? So that's, you just described what we call progressive MS. And it is, unfortunately, it is harder to slow down or stop progressive MS. I think I think trying medications is worth it. I think escalating medications is worth it. It's a very individual decision that I have with my patients. But sometimes, again, the reality is, especially if the patient is many years removed from MS, like 20 plus years, it may be harder to slow it down. But as you saw, there's optimism. There's options coming down the pipeline. And Shelley asked, do you recommend that older patients go off their long-term? So yes, again, in very individual decision, really depends on the patient. There is a study that should be wrapping up soon that's trying to answer that question of whether or not it is safe to do so, whether or not people who stop their drug will have activity. Technically, I tell people your chances of a relapse never go down to fully zero, but they become so rare that it is probably safe. And I have done so. I have taken patients who have been stable for years off medicine. Question from Linda: does MS shorten the lifespan? No. First of all, yeah. The first question I guess is, does MS kill you? No, it does not. Does it shorten the lifespan? I would say, officially the answer is yes, but I think not. In the old days when people used to reach disability much faster, people would die from complications of not being able to move, like infections, ulcers, pneumonias, things like that. But as we are making strides in being able to treat and reduce disability, we're seeing less of that. So my guess is if someone does a study today, and it may have already been done, I just don't know about it, you're going to see a difference. It's not going to be as significant.
And Marilyn has her hand up. Marilyn, would you like to?
Go ahead,
Okay,
Marilyn.
I have a question. I've always been a big believer in stress causing things. Can a traumatic event which causes stress increase the risk of an autoimmune disorder like MS? And can it also cause a relapse?
The first part is probably not. We hear this a lot. It may, you never say never, right? We know that sometimes autoimmune diseases start after the body's been stressed with, say, an infection. It could be as simple as a cold. So can I rule out that psychological stress or stress from a different kind won't result in the same thing? No, I cannot. I think people have looked at this and they did not see a link. Similarly, although I see it in my patients where sometimes they clearly feel worse after stress, it has not been shown to be associated with relapses. But again, I think anything that increases stress on the body is, people were bound to get the autoimmune disease. It's not the stress that causes it. The stress uncovered it. That's a kind of a better way to think about it.
Thank you.
You're welcome.
I have a question from Shelley in the chat.
Should someone who has seemingly done well on one of the earlier treatment? Excellent question.
So I'm going to repeat, Dr. Shahim, I'm going to repeat the question so that if someone didn't actually see the chat.
Yeah, I'll go ahead and repeat it.
Okay.
Should someone who has seemingly done well on one of the earlier treatments like Advnaces, these are the safer, less strong options, for 20 plus years, consider switching to one of the newer, stronger drugs? No. That's my short answer. Other centers across the United States, I've heard that they're switching all their patients. Again, this is a very individual decision that you'll make with your neurologist. But if you've gotten to 20 years with, knock on wood, not a lot of disability, done it relatively okay, things are stable today, it would be very hard to convince me that we need to change things. Again, if it's not broken, don't fix it.
And then Sarah said, what's considered a strong treatment?
That is, it is also relative. And again, mainly the infusions are stronger. So if we're going through the options, Ocrevus would qualify as that. Kesimpta, which is a slightly different version than Ocrevus, would also be considered strong. And then Tysabri as well. Many of us consider the family of drugs of Gilenya. I call them Gilenya and their siblings. There's now 4 pills in that category. They're called S1P receptor modulators. I think they're not as strong, but right there, right next to the ones I mentioned. And that's about where I would draw the line. Some people think of Tecfidera as strong. I think it's right on the edge of, it's right in the middle. Yeah, I think to answer the question, will I share my slides? I already emailed them to Judith, so yes.
So, and yeah, and everyone, so you know, I can send an email PDF form so that you can review them. And if you have any further questions, once you do look at them again, you can send me a question and I can forward it to Dr. Chahin if that's okay with you.
Yeah,
Doctor?
sure.
Yeah.
All right. I see, first of all, Sandra was typing and I see now you put in the, I have JC virus. They say I cannot take MS pills. No, so again, I think, that's a long conversation to have with your neurologist. The only drug with a very high risk of getting an infection from the JC virus, like a reactivation infection, is Tysabri. Half of us are exposed to this virus. Literally, if we draw blood from everyone in this room, I bet you more than 8 would be positive. And so half of my patients are positive. I don't check it if I'm starting my patients on a pill, because the risk is not 0, but it's low enough that it's not a concern.
Marilyn, I think you might have had your hand up too.
Go ahead, Marilyn.
You need to unmute, Marilyn.
Okay, can you hear me now?
Yes.
Yep.
I came from Colorado, and it's close to Rocky Flats where I live, and they produced nuclear triggers. And in that area, there was an exceptional high rate of MS. Is there anything that people in that area can do to help prevent getting it if they're exposed to these high levels of radiation?
Short of moving, if true, right? No, the short answer is probably not. I think I find it fascinating. You kind of hear of these clusters of cases, and some people, there's many possible things in the environment to blame. I think the best thing to do, short of being able to move, and by the way, it matters if you move before puberty. Your risk is acquired right around puberty. So it would be to participate in studies, try and understand what that risk is so that future generations will be able to avoid it.
Thank you.
Okay, and another question also. So you were saying for secondary MS, disability severely increases despite disease-modifying treatment. Is there anything I should do in the short term? No, I would say we don't know how things would look like if we stop medicines. So again, if you and your neurologist feel like the medicine you're tolerating the medicine, okay, I would say continue it, because I would worry that if you come off of it, you'll notice even more things getting worse. But nothing else to do in the short term. Take your vitamin D. We used to say take biotin, but then there was a large biotin trial that was a negative trial. I did not even mention it today, unfortunately. And then, yeah, stay tuned. Things are potentially changing.
I've got one other question, if unless somebody else has one.
Go ahead, Marilyn.
Okay, is there any way that you could say approximately what percent genes play in MS? Because my doctor told me laughingly, I asked him a question of something else, another disease, and he answer to me was, choose your parents. And is there one parent over another that might make you more susceptible to getting MS, your mother or your father?
No, I'm not aware of any studies that have looked at whether or not and they've identified over hundreds. I don't know if it's now over 200-300, hundreds of possible gene locations that may make people more predisposed to MS. I don't know if any of them are on the sex genes, but I don't think so. The short answer is no, probably not.
Okay, thank you.
Sure.
I think we have another one from Sarah. How do you determine if someone has relapsing, remitting, or progressive? Circling back to the first question, if someone is diagnosed with relapsing, remitting, but their scans are stable, but disability is progressing, then does the diagnosis change?
Yeah. So relapses mean, it's something that's relatively sudden that starts over 24 hours, gets worse over 24 hours. So clinically, basically, is hearing the story. If I hear a relapse, that's relapsing MS. A better way to think about it, Sarah, so your question brings up the newer way we're thinking about things is instead of labeling, because it doesn't really matter, labeling MS. If I see new lesions or if I hear a story of a relapse, that's a relapsing MS. Even if underneath it, you have progression. And if I see relapsing MS or I call it disease activity, I'm going to treat. The opposite is if someone every year says they're a little bit worse than the year before, with or without relapses, that may be called progression. Again, there's more definitions. So I just describe the patient instead of labeling them because I'm treating what's going on with the patient. I'm not treating the label.
Do we have more questions? We have time for one more question possibly, and then we have to end the program for today. One last
One more question. Could you have a relapse without changes? Probably not. Could an MRI miss a lesion? That's probably a better way to think of it. Is if someone has a relapse, we do an MRI and we don't see anything new. I think this is where clinical judgment comes in. If I believe it's a relapse, I don't really need an MRI. If I'm doubting it's a relapse and the MRI doesn't show anything new, then I'll take it into consideration. So probably not, but I use my clinical judgment.
Thank you. Thank you so much, Dr. I appreciate everything that you have shared with us today. Is such a wealth of information and a lot to digest. But as I said, I will share the PowerPoint in a PDF form to your email. And if you have any questions, this is also being recorded. So if you want to watch the recording again, it is on our website and I can send you the link to the recording. And you just gave us so much information and it was very helpful because I could understand it.
That's the goal. The goal is for everyone to be able to get what's going on.
Thank you.
No
Thank you,
problem.
everyone.
So much.
Thank you,
Thank
everyone, for
you.
being here
Thanks
today.
very much.
And
Thank you.
thank you again.
Thank you all for
Bye-bye.
attending. I appreciate it. Thanks.
Okay.
Bye-bye.